years. What's the retirement age for this particular profession? X amount. What would he have earned? There's a formula for that. And they multiply all the years and say loss of future earnings. Especially if the person who died was a breadwinner, then there's a loss of future earnings. That contributes significantly, number one. Number two, pain and suffering. This person underwent severe pain and suffered before they died. Now, this is at the discretion of the court. Okay, let's see what happened here. So, that hypoxic brain damage here now. First plaintiff hereby awarded a total of, first plaintiff is who?
The patient.
The patient has been awarded how much?
43 million.
43 million. This is not a case of today. This is an old case. Can you see special damage was how much? Only 1 million. Because this is what was actually spent for the patient. The general damages were 43 million. First and second plaintiff were to pay, second and third plaintiff were awarded 1 million each. These are the parents now. Okay? A declaration that the acknowledgement of debt guarantee dated that extracted, this is to pay 1 million being hospital cost is unenforceable. So, you are being told, first of all, to pay special damages, and the hospital bills were waived by the court. That's why the court is saying here that the third defendant was supposed being hospital cost is unenforceable against the second plaintiff. So you are paying and you've lost what is due to you. We are not paying you. So you are getting nothing at the beginning. So we start from there. First of all, you are getting nothing. And then we charge you. How much now in total? About 46 million. That's how much this statement, this judgment was. And then, so number one, we apply for special damages, general damages. Number three is cost. Cost of the suit. Cost follows the decision. You lost, you pay. So who's going to pay for this whole process? Defendant number one, number two, and number three. They are going to pay for the lawyer's fees, they are going to pay for the filing fees, they are going to pay for the entire process of the plaintiff, of the patient. You are going to pay. And number three, until you pay from the date of the judgment, the interest. Those are the 4 or 5 things that lawyers ask for in court.
This will be equally divided in.
So what it's not as simple as that. I will sue the one who is most likely to pay. Who is that? And then it's up to the hospital to chase the money from the other two. I will follow the hospital, let the hospital chase money from the other two. So that's also a tactic that is used. And that's why when you say this, because they are able to pay, that's also allowed. I don't have to chase all 3 of you. I can pick any one of you.
So mostly in this case, hospital is only the one which is bigger.
And then hospital, you're supposed now to chase the other 2.
But then that becomes a personal discretion. If the hospital chases also, and if the other 2 parties are not willing to partner in that. So
then if they're not willing to pay, you apply for their bankruptcy and attachment of their property. You can apply for them to have their property attached, and that's happened. There's a case that I was involved in. A patient, the patient died. Obstetric case, patient died. Why? Cervical tear. Awarded 50 million shillings. Now, unfortunately, and this is a policy, Mr. Momin, Daktari, which you need to have as a hospital. Who receives your documents? These documents from the lawyer, demand letter, was received, stamped, put in the drawer by the front office. Court documents were received, stamped. Remember, you stamp your documents and you stamp the person sending. So here's a copy of your stamp that you have received. And then they were put in there. The first time we are hearing this judgment of 50 million was in the newspapers. Yes, that's the first time we are hearing about it. Okay? Remember, we are hearing it for the first time in the newspapers. So we say, but we were never served. They bring, here is the evidence, you were served. So it went off as an undefended case.
So in ideal circumstances, this should have been received at the medical director's office.
Now it's hospital policy. I don't care. Did you stamp received? So what's my problem? So that's your internal policy. That's why I'm asking Mr. Momin and the medical director to institute policy and never have a received stamp at the front office. Because the minute you stamp received, my job is done. You have acknowledged. Now guess what? When I reviewed that file, so I went into this organization after this has happened. I reviewed the file. The lady delivered by cesarean section. So how did they get the cervical tear? Exactly. So we could have defended this case, can you see? And won, but we lost. So again, we get sued. We have bad reputation because of our internal processes. This was a completely defendable case. We lost 50 million. 50 million.
Sir, in this particular case, what you are saying, if the patient has not died,
yes,
and if due to any surgery the patient has loss of vision or loss of hearing, or maybe if there is an arm injury or a leg injury and that was amputated because of post-operative infections.
Yes.
If there is a gangrene or anything and you had to amputate afterwards, what happens in that case?
So in this case, remember, any amount of money that was accrued afterwards you could not collect. That's your cost. What has happened? Yes, that was your cost. So you can't claim back. You do the treatment, you are the one who caused the harm, you end it. So why did I start by saying what are the commonest sources of suits? Hospital acquired pressure ulcers. You caused them. That's the interpretation. Hospital acquired infections. You caused them. Why are you charging me for your negligence? If it wasn't your negligence, I would not have gotten a hospital acquired infection. I would not have gotten a hospital acquired pressure ulcers. You understand?
But in the hospital acquired infections, is the clinicians also involved? Are the clinicians involved?
So it depends how they are put out there. So what they are finding out, many of the lawyers, the soft spot in some of this, like hospital acquired pressure ulcers, is through the nurses. And that's why I started by saying the nurses have to document it carefully. Because now the people being attacked are not just doctors, are also nurses, are also laboratory technologists and laboratory team and physiotherapists, nutritionists. So everybody is now being taken to task. So let me move quickly because I want to make a point. So if you look at the issues that were raised, late arrival for the scheduled procedure, failure to properly and adequately prepare, failure to carry out a complete history and physical examination, failure to make an appropriate evaluation, failure to observe proper and reasonable care, not monitoring vital signs, failure to exhibit reasonable care and skill in the treatment. Which of these are not avoidable? So we get sued for these reasons. And a lot of this is related to what? Communication. If you're arriving late, please let your clients know and then document it. What are other areas where we are very poor at documentation? Nurses do it all the time. Doctors do it all the time, but we never document it. Vital signs. Patient education. Patient education is done almost routinely and never documented. So when the patient says, he didn't tell me, it's your word against mine. So we don't document. So documentation is one of the biggest reasons why we get sued.
Another is improper handover. When the nurses are changing duties, even that also causes a lot of mistakes.
So I don't know if I captured that somewhere. So I've discussed non-medical standards. So I'll come to that in a second. So one of them is lack of clear communication with patient and relatives and lack of clear documentation of the foregoing. I think I've overemphasized on this. I think the next one now was about Okay, so let's discuss a little bit about handover. Leave alone handover, any point where there is a handshake. What does a handshake mean? Two clinicians that exchange information. I shake your hand, you give me some information, you take some information. When do we shake hands in the hospital?
When you are referring a patient,
When you're referring a patient,
when you are including another clinician into the
when you're including another clinician. You see, these are the obvious ones. Handover, nurse to nurse, handover, doctor to doctor, especially here in A&D. I've seen this patient, I've gone off, you have come, you're supposed to continue the care of this patient. That handover is a major risk factor. Importantly, phlebotomy, when you're going to bleed this patient, what were the instructions? That's a handshake that we omit. You see, I'm saying in this context. In other contexts, it will be at the time of feeding the patient, at any time where a staff who is not taking care of this patient comes in contact with that patient, there is supposed to be a handover. This patient is diabetic, yet he's been given jam and tea with sugar and uji with all these things. Who checked? There should have been a handshake. Sindio matter? Yes. So how did that patient ended up with that jam? So any point of interaction between a person not taking care of the patient to somebody who was taking care of the patient, that's an opportunity for errors. Okay? Now, let me give you a scenario. You have a 70-year-old female, diabetic, hypertensive, intermittent diarrhea for 4 days, no weight loss, no dehydration. Investigation she came with, normal hemogram, you see normal occult blood in stool. What will you do? What will you do? Sorry? Vitals? Sugar? Pressure? And then what? Now, what if this patient, then these are the results of the investigations. Now, what will you do in this case? Clinicians, what will you do? People working in A&D. Who works with A&D at the A&D department?
So basically the main thing is not stool in the blood, not blood in the stool of this thing, but it is shortness of breath on mind exertion.
So what will you do? How do you manage this patient?
So first of all, clinical findings have to be seen.
Using the
Second.
Yes.
With the light of because the patient has this crackle, HB is 9, urea is more than 7.
Okay.
This is a patient who requires HB setup.
Okay. And this one, what will you do? What will you do for this patient? Antibiotics?
First of all, sample to be given for urine culture.
Urine culture? Okay. So, this patient, you will manage in A&D, you will want a repeat of these investigations. You cannot take responsibility of another laboratory's investigation. And if you do, then the responsibility shifts from that laboratory to you. Now you, from that point onwards, you are responsible. You cannot say, I relied on these results and they were wrong. But you relied on them knowingly. So you become responsible. What do you do with these two patients is you refer. Stabilize and refer. That's the bigger lesson. Now all of you are saying, oh, you will do this, you will do that. No, you will not. This first patient doesn't have pneumonia, daktari. This patient is bleeding in the stomach. That's why the urea is high. Now, the patient is so anemic that has gone into heart failure.
So first of all is...
Why is the urea high? Because there's blood in the stomach. And you have microcytic hypochromic. So it's long. Now he's gone in an acute bleed. There is blood in the stomach. That's why the urea is proportionately elevated compared to the creatinine. So this is, what are the conditions that give you this? Now if I'm going to my medical lecture mode, urea disproportionate to creatinine implies? What renal? Pre-renal. What causes pre-renal? Sorry? Dehydration. Any massive fluid loss, not just dehydration, even hemorrhage, anything will cause that. That's number one. Number two, hypercatabolic state. Number three, blood in the stomach. Number four, wasted patient. Creatinine is from muscles. Wasted patient. This patient has severe renal failure, but because he's wasted, it looks slow. See, so as a nephrologist, this comes to me like that. But you don't know that. So you must refer, stabilize the patient and refer. You'll get sued for not referring to the, what are the AAA Qs? Accessible, affordable, acceptable, and quality. Quality includes appropriate treatment. This wasn't appropriate treatment. These are the patients. What does this patient have? Now, because I'm a nephrologist, I'm giving you renal examples. Had you done fresh urine microscopy, you'd have seen casts. This is a patient with acute glomerulonephritis. You are thinking because of the WBC, this patient has urinary tract infection. No, it's not. It's not urinary tract infection. This is actually acute glomerulonephritis with acute renal failure. Your creatinine is already rising and you are busy sending this patient home with antibiotics. So the other reason why we get sued is we are swimming beyond our depth. You are a shallow end person, you are swimming in the deep end. Refer. If your area is... So I used to be excellent in doing liver biopsies as a GP, as an MO. Excellent. I was really good with my hands. Most procedures, lumbar punctures, liver biopsies, they would send them to me. Now I'm a nephrologist. I have a patient who needs a liver biopsy. Can I do it?
No.
Exactly. You see what I'm saying? Why?
You're not a specialist.
Because I'm not only am I not a specialist, is a specialist available? You know, if there was none, then I could get away with it. That's why MOs do cesarean sections in the districts. It's perfectly fine. But you can't have an MO doing cesarean section in Jalaram when you have obstetricians. We are together. So appropriate treatment and appropriate referral. Now I've just given you examples that look so obvious to you that this was a urinary tract infection, and I've shown you it was not a urinary tract infection. This was an acute glomerulonephritis. Now what makes me very sad is if you don't treat this patient appropriately, when it's acute, you miss the boat, this patient comes back to you 6 months later in end-stage renal failure. You do a biopsy, you find fibrosed kidney. Too late. We could have done something 6 months ago at this stage when you should have referred. Why? HB is 12. This is acute. Patient has not dropped the HB. This is an acute problem. We could have salvaged this patient. Now, this is a patient that made me very, very sad. The patient died. Why? He couldn't afford dialysis. Dialysis was a death sentence. This patient came 6 months later at end stage. And this was many years back, before NHIF doing dialysis. So, a breadwinner, we could have saved these kidneys 6 months ago. Now, go to court. Call Majid to come and testify. What will I say? The doctor should have referred 6 months ago. Do you have a leg to stand on? The hospital should have put in a system that the doctor refers early. Do you have a leg to stand on? Okay? So, documentation, knowing when to refer and when to treat. Prescriptions get us into trouble. We are moving away from Latin abbreviations. Please stop using them. What's so difficult about writing this? Why don't you just write once daily? Why don't you just write twice daily, thrice daily, 4 times daily? How much more seconds will it take you to write it like this? My wife, when she knew I was preparing this, she gave me a case. I wish I had my whiteboard. So somebody had snake bite. Okay? A young child in Ukambani. They wrote, give antivenom 1 vial. Start. Okay? Then he consulted, how many vials? No, it's not 1, it is 2. So what did they do? They cancelled the 1 and wrote the 2. What does it look like? And what did the nurse give? Half a vial. Yes. Because it was 1, then a line, then 2 below. What is that? Yes, the patient got half a vial. What was the patient supposed to get? 2. Now the patient gets half a vial. So this antivenom, is it effective? So do you have a duty of care on this patient? Yes. You have a duty of care? Yes. Did you breach it? Yes. Did it cause harm? Yes. So you are negligent. Therefore you are negligent. You understand? So do you have a policy on how to cancel? Do you have a policy, first of all, on how to write 1 and 2? 1, 2, 3, 4, 5, 6, 7, 8, 9. Do you have a policy to write this? So from 1 to 9 should be written in words. Anything above 9 is written in numbers. As a general rule. So you don't write 1, you write 1. So if you cancel and write 2, it is very clear it is 2. So stop writing OD, write once daily. Stop writing number 1, write a full 1. Stop writing PRN, change it to as necessary. This is inadequate. You will still get sued for it. Change as necessary to, for what reason? As necessary when what happens? As necessary with what event? Give Valium 10 milligrams PRN. With what? With fits. You have to give the condition. Now, the last bit, which I forgot to add here. You must state the maximum number of times this can be repeated in 24 hours. So I give 10 milligrams of Valium. After 15 minutes, they have another fit. So what do? I give another, then I have another fit. But you didn't stipulate, you said what? PRN. Now you have improved, so you said PRN with fits. So the patient is fitting. So I give, then I give again, and I give again. Okay? So 5 milligrams, write it as 5 milligrams. Do not put a 0.0, please. Better still, I would say change it to 5 milligrams, or full if you want. Better change to 5 milligrams, because it's a number less than 10. 0 to 9, change to full. We are together. Don't put 0.5. Can you see this is a 0.5? There is a point here. Had you even seen that point? So 0.5 can be mistaken for 5. 5.0 can be mistaken for 50. So do not use this kind of, that is prescriptions that get us into trouble, that have gotten us into trouble in the past. The other one that you should not be using is this one. What is this? The first one is micrograms, and the second one is Units. No, these are prescriptions that you should never be using. Please write micrograms in full and write units in full. Practice that gets us into trouble: documentation, early referral, prescription. Now, my last slide, consent. Injecting a patient without consent is assault. Yes. Sawa. You can get away by saying the patient came to hospital. By the time the patient came to hospital, it implies consent. Okay? You will get away with it, depending on the level of invasiveness of the procedure. If you're just checking blood pressure, temperature, you will get away without having a consent. Hear me? You will get away without having a consent. But the more invasive you are, the less you will be able to get away without a consent. You will not get away without a consent with lumbar puncture. You will not get away without a consent with phlebotomy. You will not get away without a consent with doing bone marrow biopsies and liver biopsies. You will never get away without a consent for doing surgery. We are together? Yes?
Then in phlebotomy, I think when a patient walks into a room, not I think, in our practice, when a patient walks into a room, we take that as proof of consent. Okay, sorry, let me come up again. When a patient walks into a room for a maybe phlebotomy bleeding, we take that as a proof of consent.
Okay.
Yes.
What are the side effects of phlebotomy?
They could be having a hematoma.
Assuming now it's a 3-year-old child who is been fed with pawpaws and pumpkins, is nice and chubby. What are the side effects of phlebotomy?
One, you may miss a vein and do 2 or 3 attempts.
Okay.
Yeah.
So 2-3 attempts, that's one complication, which the parents were going to complain bitterly. Did you tell them that you might go 2-3 attempts?
Not in most cases, but we do.
Okay.
Inform.
What's the other side effect? Thinking you're putting it into a vein and you're putting it into an artery, because I've seen that, and resultant gangrene.
Hematoma?
Hematoma, gangrene, extravasation, and causing an ulcer.
Yes.
Did you inform them that this would happen?
So in such a case, you
Where's your evidence? So what I'm trying to say is categorize your risk. If it's an adult, you can get away with it. But make sure for a child, and for that matter, if I dare say this, in females, because their veins are harder to find, you might get into trouble. So it's better that you just sign a consent. Just takes you 5 seconds. Yes?
So even after consent doesn't apply in this case?
So that's how we try to overcome it, by having a general consent. Okay, now let me dissuade you from that. Consent by law must be specific. You cannot take a general consent that I'm going there, if I find this, I will do this, and I find this, I'll do this, and in case I find anything, I will also sort it out. See, that's also a consent. No, that consent will not fly. So consents must be specific. So if you are going to do 3 procedures, you must take 3 consents. Or at least those 3 procedures clearly documented that I'm going to do this and this and this. Signed for all 3. Signed. Okay. Now, with consent, let's go step by step. So consent needs to be detailed. Consent needs to be specific. You will get away, now depending on your risk. The lower the risk, the less the consent required. Okay? So you get away with consent without a consent for procedures that are non-invasive. You will get away with it. What is the level of invasiveness? Is it just venous? What about digital examination, rectal examination, vaginal examination? Is that an invasive procedure? Do you take consent for them? Do you take consent for them? So consents need to be specific, eh? Yeah, you cannot have a general consent. So this general consent of coming to hospital, I give my consent to do everything and anything you want to do unto me, that doesn't fly. Yes.
So if I may ask again, now if like we have like over 100 patients to do bleeding,
Yes.
and we also
What's your risk? How many
Okay, that
times
can be
have you
assessed.
complicated? If your risk is so small, it's 1 in a million, take the risk and say, I will not take consent. Because this matters only when things go wrong. You can go to surgery and open the brain without a consent. And he comes out very happy because he's been cured. Will you get into trouble? No, because he's very happy. The day things go wrong is when these matters come to bite you. So what's your risk? So if phlebotomy you feel, and this is not legal, it's institutional policy and risk profiling. If your risk is so small, don't burden yourself with consent. But I'm just giving you as a rule of thumb, the more invasive it is, the more you need the consent, because the more likely things to go wrong. Okay? So I'm not giving you one way or the other, I'm giving you a general guideline. Yes. 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 Of course. Of course, you must have consent. Verbal consent is okay. You document it. Then how is it taken?
patient will refuse.
And that's perfectly fine. Get the patient to sign, or at least say consent verbally obtained, and sign off. Yes. It's not as strong as if the patient has actually written.
Yeah.
Now, with
Doesn't ask for it.
Yeah.
If it's asked for it.
No, it's not. Even if the doctor asks for it, if the patient has not consented, it's still not okay. Yeah. Just because the doctor asks for it doesn't absolve you. Now let me give you another story. Somebody was having severe headaches, an old lady about 7 years old. It was in the old MPS records. And she said she had like 4 teeth. And she said the reason why she's having this headache is because of her teeth. So she went to the dentist, said, pluck out all my teeth. The dentist said, this is not the cause of your headache. She went away. She came back. She said, remove all my teeth. The dentist refused. Went away, came back. About 3rd or 4th time, the dentist was fed up. He went ahead and removed all her teeth. The children of this lady sued, and the dentist was found liable. It does not absolve your professional opinion. Just because you've been told something doesn't mean I do not have a professional input into this. So you cannot absolve your professional input. So the question will be asked in court, was extraction necessary? Your answer is? I have no further questions. Okay? So please be careful. Invasive procedures, private procedures. Now, coming to private procedures, you're a female doing that. Risk is? You're a male doing that. Risk is? You understand? Yes, so it depends on your risk. So the risk of a complaint goes higher. I had a colleague friend, a lawyer, who was done a digital examination by an obstetrician. And she said, a male obstetrician, she said she felt invaded. Yes. So, what is the protocol here in Jalaram? Male patient examining a female patient. Male doctor examining a female patient. Female doctor examining a male patient. What is the protocol? Chaperone is. So, is that, did you have to think about it? So, the best practice is So I rest my case. No further question, Your Honor. You understand? So even the practice, so when you're conveying sensitive information, always have a witness. Yes. The other area where we get into trouble is in the HIV tribunal, which is related to informed consent. And in HIV specifically, and pre-testing. What's it called? Pre-test counseling. Pre-test counseling. Yeah. Those two things get us into trouble all the time in the HIV tribunal. HIV tribunal is at the level of a magistrate's court. So it's as good as a court. They can fine you. And it is binding to you. You can appeal not to magistrate's court, to high court. So tribunals are the equivalent of a magistrate's court. So we get sued. Now let me summarize so that we then take questions if there are any additional questions. Why do we get sued? Poor documentation is the commonest reason why we get sued. Number two, assumptions. Because it's an ENT problem, I only looked at the ENT area. We've had a patient who has an ulcer and was severely anemic. Severely anemic. There's a patient the surgeons were going to theater, believe it or not. I was passing by as a visitor. Because they knew me, they asked me to examine the patient. Patient had effusion up to here, Daktari, that they had missed, and the patient was going to go to theater. The patient would never have woken up from the table. Yeah. Chance. Why? Because it was a head and neck procedure. They didn't examine the patient below the neck. They didn't examine the patient at all below the neck. Yeah. Do a quick examination. Check the pulse rate. Quickly. Look at the eyes. You know the basic thing, not, what do you say? No edema, not pale, not jaundice. Those things, those basics, please do them. Then you do systemic quickly. Chest is clear. Cardiovascular is normal. Per abdomen, no organomegaly. You know that basic. That is the basic, mandatory. You must do for all your patients. You must do that for all your patients. Okay? I have a patient, 40-year-old female, who has chest pain. What goes through your mind? What more information do you want? That's the first thing you should do. Then, so what more information do you want? Good, excellent, character of pain. Why do you want the character of pain? Because in your mind, chest pain, you start, is it skin? Is it muscle? Is it bone? Is it lung? Is it heart? Is it nerves? Those are the structures that are there in the chest. And each one of them has a different character. Isn't it? So, character of the pain. Now, you want to tie it up with a bow. 40-year-old female to have a cardiac problem. So this pain radiates to the neck. So what's going on? Points to cardiac, eh? Yeah, radiating to neck and shoulder is cardiac. 40-year-old female, chances are low. What risk factors do you want to ask for in the history? What do you want to look for on examination? So first thing, family and social history. We don't do genetic studies, but genetic studies manifest phenotypically. Yeah, so if there's a genetic problem, it will be seen in the family. Do you have anybody in your family who has died below 50 years old? Yes, my grandmother, not grandmother, my auntie died when she was 45. Now you have a family history of early death in a female. What's going on? Now when you're going to examine, what do you look for? You start looking for xanthomas and the xanthelasmas. You start looking for certain things. This is not something you do for every single patient. That's what I'm trying to say. There's some basics which you must do. The others you are guided by your history and your initial examination. That leads you to more to do. So you don't take a history of xanthomas and xanthelasma or examination on every single patient. But you are guided by what you find initially. But what if you didn't find anything because you didn't examine? So, very focused examination, we miss a lot. The other one was poor monitoring. One of them I forgot, that's very, very important. I should have put it here. A patient comes to you with fever of 38 degrees, chills, rigors, vomiting. Examination, kila kitu, spleen is slightly enlarged, blood slide, malaria positive, treat for malaria, patient feeling better, discharged home. 2 days later, patient dies. You go to court. Are you negligent? Patient had malaria, confirmed on blood slide. Okay, so this is what the lawyers will ask you. You said the patient has headache. What happened to the headache? You have not documented. Subsequently, you haven't documented. You also said the patient has fever. What happened to the fever? You haven't documented. You said the patient had rigors. What happened to the rigors? You haven't documented. So what am I establishing as a lawyer? Incompetence. This doctor was incompetent from the beginning. He couldn't even follow up the headache and the rigors that the patient complained about. So you must follow up the patient's complaint to resolution. Patient had pain. What happened to the pain? Okay, guys, I hope I've given you a snippet on why clinicians now, not doctors, get sued. Okay? Yeah. I'll stop there. Any comments or questions? Yes. Intentionally so that
We are handling quite a number of patients during bleeding, that's phlebotomy. I think, I don't know whether it will now imply that we put on some policies, maybe consent kind of.
So let me ask you.
All
So let me ask you.
Because
So let me ask you a question. Let me ask you a question related to that.
Yeah.
What do you go with to bleed the patient? Tell me the things you go with.
Now we go with our basic phlebotomy kit.
How do you know which patient to bleed?
Okay, it surely depends on what the doctors requested.
Requested where?
From clinician from the casualty or any other.
Where have they requested?
Within the hospital.
Where?
Within the system.
System. So in that system, can you put somewhere an element of consent?
Okay.
So that you can say, consent taken, tick. Even if it's verbal, you see that's a low risk procedure.
Yes.
So as long as it's not automatic, you have an active process where you go and tick it. So you ask the patient, I'd like to bleed you. Isn't that what you ask?
Yes.
Is it okay if I go ahead?
Yes.
Isn't that consent? Where have you documented it? That's all I'm asking. It's a low risk procedure, verbal is adequate. But you need to document it. It's a low risk procedure, so verbal is adequate. Okay? Yeah, so you don't have to generalize for every single person. The low risk procedure, just take a verbal consent. It's perfectly acceptable. But document it then. Yes. But the high risk procedures, you could say for babies, I will actually take a written consent. Because people have been sued for pricking their babies multiple times. Somebody was sued for pricking the babies 6 times. You got sued for pricking the babies 6 times.
Thank you very much, Dr. Majid.
Thank
This
you.
is indeed one of the most important CMEs I've ever attended my whole life. I'm grateful for you taking your time to come and hear us. I pray that from this we can take at least 3 very important points that are important for us going forward, low-hanging fruits. 1, we be diligent in what we're doing in the care of our patients, be thorough examining the patients. Number 2, let us document. Number 3, let's focus on this business of consent. These are areas that are emphasized over and over again. And if you can do just these 3 things, I think we will be in a better place, Dr. Majid. Have I missed?
Importantly, just the protocol on examining female patients and male patients.
Yeah.
Yeah.
All right. Is there any question? Because the time has really gone. But,
Oh, I didn't realize you didn't. You should have waved at me. I didn't realize it's 2:30.
This one cannot be interrupted.
Wow.
It can continue until 6. Please allow me to request one more thing, because we are recording the session, it's actually live right now, but we missed the first section. So please allow me to take us back to the very beginning for the purpose of the documentation.
So let's do this, Doctor. It's boring to repeat the same thing unless most of you are not here. Whether we can re-record it separately.
No, it's okay. Just the first introduction.
The introduction.
Yes, the team can proceed. If there's another question, we can proceed. I'll take up with Dr. Twahir just the first part and the first line. That's okay. Thank you very much.
Thank you. So I come back here and go to the beginning.
So just because we were discussing team.
Okay. From here. Okay, so just to repeat for the people who missed this, my name is Majid Twahir. I'm a medical doctor and a lawyer at the same time. So I just want to discuss briefly on why doctors get sued. And the commonest reason why doctors will get sued is not criminal, is civil. So all cases are divided either into criminal or civil. So in civil means a wrong against another person, not against the state. So stealing is considered as a wrong against the state. So negligence is what you will get sued under. So negligence has 4 elements. So the elements of negligence includes duty. So do you have a duty of care? If a patient comes to you, this is a given, it's automatic. Because you'll be asked, do you have a duty of care on this patient? The answer is always yes. Now, if there is harm, it's almost implied that there is a breach of that duty. So you breach the duty of care. Now, that's not enough to cause negligence. So you could have had duty of care. You could have had a breach of that duty, but did it cause harm? So that breach must cause harm for it to reach the threshold of negligence. And then there must be causality between that breach and that harm. So you are supposed to do X, you didn't do X, and it resulted in Z. Was there a connection between the two? If there's no connection, then again, there's no negligence. So these 4 elements must come together. So it's quite common to be able to tie this together and fairly easy, because the first question we ask is, you had pressure ulcers. Does the nurse have a duty of care? Yes. Was there a breach because this pressure ulcer was hospital acquired? Yes. Because of your breach, did you cause a pressure ulcer? Yes. So there's a direct connection and that there was harm. What did the pressure ulcer do? It caused additional hospital stay, so there was damage. They caused additional cost, so there was injury to the patient. And then there is causation. So those is the elements of negligence that are straightforward. Yeah. So then these cases, to illustrate, I've picked a case that is rich. It's an old case of 2008 that involved a patient and who had hypoxic brain damage. These cases are readily available. They are not private. They are there in Kenya Law Reports. If you just go to type Kenya Law Reports, Google that, you go to Kenya Law Reports, go to case reports, and you will find under that case report, type medical negligence. And this case will be among the top 3. So this case is a public information. They're not secret, they are open to everybody. Yeah. Okay.
Just one last request.
Yes.
We'll just go back to the very first slide and we'll start by just, we limit everything just to ask the team, good afternoon, welcome to this CME. Then a proper introduction, then everything else will be good.
Okay, good afternoon everybody. Karibuni to this CME. We are discussing an important issue on why doctors sued. This is an ongoing series of CMEs that we do regularly at Jalaram. My name is Majid Twahir. I'm a physician nephrologist and I'm also a lawyer. Karibuni. Asante.
Sorry for the oops.
No, that's perfectly fine.